Thanks, Chairman, and it's my honor to be here to talk about the stepwise approach to calcified lesion. So today's presentation, I want to start with changes in recommendation treatment technology for coronary calcified lesion in recent 10 years. We also know during before 10 years, when we met angiographic calcified lesion, we only use a high-pressure balloon to predilate or use a rota. We don't have another effective weapon to treat calcification. But now we have a lot of effective weapon. One is OPN with very high pressure, very high pressure balloon over 35 bars, even though this is not available in China. Another is cutting balloon. We also have used routinely when we treat mild to moderate calcification detected by angio. So the third is intravascular lithotripsy is very attractive now by a lot of experts in daily practice. The fourth is the RotaPro system is a new system compared with the old system is quite effective for the operator. The third is Orbit, it is not available in China now. The last one is the laser. Laser is effective for the fibrotic lesion, but for severe calcified lesion, we don't have a lot of evidence from now. But now we have 6 very effective weapon for the calcified lesion. For different mechanism for rota compared with orbits, we also know the mechanism was just make the thickness of the calcification thinner. It's by just not only compared with shockwave balloon. Compared with orbits used before and after, we also find that the thickness of the calcification becomes thinner and thinner. But compared with orbits, rota, the similar wire bias phenomenon, we cannot avoid it. That means the rota bias position maybe the effectiveness of modification or debulking for the calcified lesions. So different cutter mechanism of rota is superior to orbits, and but for a single burr make the lumen larger and superficial calcification or small calcification, orbits superior to rota. For shockwave balloon, the mechanism was make the calcification crack, not the thinner. So for laser is just indication for the laser is also for the underexpansion of the after standing, especially for severe calcification. So, but now in 2023, GW-ICC published a journal. Published a paper focused on the intravascular imaging guided PCI for calcified lesion. If we find the CVI score with essential calcification less than 4, okay, we can use the NC balloon, cutting balloon, scoring balloon to predilate the lesion. But it's the CVI score detected by OCT over 4 means O equal 4. We use rota orbits or little shockwave balloon to pre-treat the lesion before standing. But for calcification or longitudinal calcification, we should use a rota or orbits or a shockwave balloon to pre-treat. We don't need to use an NC balloon to predilate the lesion with a calcification or longitudinal calcification. So we just focus on the flowchart recommendation treatment for the coronary calcification in recent 10 years. In 10 years earlier, there is flowchart recommended published in cardiovascular intervention. We also find that when we met a calcified lesion detected by angio with a mild lesion, okay, we can treat it without any atherectomy. But we find that a moderate lesion, we can use intravascular imaging to detect the lesion first. But for severe lesion, we should predilate or atherectomy first, then recheck the intravascular imaging to guide it. But at that time, we don't know how to treat the calcified lesion. We don't know, we don't have any recommendation from the flowchart of the calcified lesion. And in 2019, there is an flowchart of the recommendation for the calcified lesion from here. If we find the angiographic moderate to severe calcified lesion, we should pre-dilate. After that, we check with intravascular imaging, which OCT is superior to the IVUS, just because OCT can find the thickness of the calcification. If the CBI score was less than 4, okay, we can use NC balloon, cutting balloon, scoring balloon to pre-dilate it. If we find the CBI score was over or equal to 4, we can, with deep calcification, we should use, without deep calcification, means superficial calcification, we should use rota or orbits or combined with a shockwave balloon. If we find that this is deep calcification, so first choice is shockwave balloon. So if the lesion was could not cross with a balloon, so we prepare the microcatheter. If microcatheter cross the lesion, okay, we change the wire to perform rota or orbits. If the microcatheter could not cross the lesion, okay, we can treat it with a CTO lesion. And that time, after that, we should pay attention to before standing. We should make sure the optimize balloon expansion before standing. After that, we can stand it. After standing, after post-dilation, we should check with intravascular imaging to make sure the in-stand expansion was very good, touch the ultimate criteria. If still on the expansion, we can use NC balloon and very high pressure balloon, or bear out to use shockwave balloon, but it's not recommended routinely by some experts, just because maybe directly use a shock balloon post standing maybe destroys the polymer. We don't know detail. But now next year there is another paper published in another journal. We can find some exchange to the stepwise approach management for severe calcified lesion. If angio finds the moderate to severe calcified lesion, so we can find here, if detected with intravascular imaging, IVUS or OCT, we can also calculate the score. If the score was lower risk, okay, we can use NC or OPN. OPN with very, very high pressure balloon and cutting balloon to pre-dilate the lesion. If the intravascular imaging finds the calcified lesion, okay, use atherectomy. If the find the deep calcification with a higher calcification score, we can use intravascular image literature, means shockwave balloon. After optimal balloon dilation, we should check the intravascular imaging again. We don't need to put a standard again, just we should check the intravascular imaging again. If we find the calcification modification or track of the calcification, okay, we can stand. After standing, we should recheck the intravascular imaging. So, but now today, this year there is another recommendation published in JACC-Asia. It's quite easier, and compared with angio, should use intravascular imaging guided PCI, no matter OCT or IVUS. OCT or IVUS find the deep calcification. Okay, we can use NCL scoring or cutting balloon to pre-dilate it. And then, if we find a superficial calcification, calculate the IVUS or OCT score to. If the IVUS or OCT score was higher, okay, we can use rota, orbits, or shockwave balloon. If the score was less lower, okay, we can use similar with the deep calcification. If we find the longitudinal or calcified lesion calcification, we should use rota or orbits before pre-dilation. Okay, if we lesion was uncrossable lesion, okay, we can use a microcatheter or smaller balloon to pre-dilate. If still fail to use, compared with a CTO lesion. If the calcification, severe calcification with a clot, okay, we cannot use rota or orbits. We can use a laser or intravascular lithotherapy. Okay, if we underexpanded with a stand with laser or bear out to use shockwave balloon. If still, okay, after that pre-dilation, we should recheck the intravascular image to find the calcification modification or crack of the calcification. Okay, we can stand. After standing, we can perform post-dilation. After post-dilation, we should recheck the intravascular to want to get the full expansion of the stand. So my current understanding and management for coronary calcification from this case with 73 years old female with hypertension, high risk, but the patient came to our hospital combined with ACS, just ACS. We also find that the lesion located at the distal RCA, with just because the RCA was dominant coronary artery. But this patient was only a small lady and a very old patient. This is just a lady, and we checked with OCT. OCT find a very interesting information. From here, the distal part of the RCA with typical calcified logium, but from angio, this is only in the mild calcification lesion located at the distal part of the RCA. So we also measure the distance from the tip of the calcification to the lateral wall. Here is nearly 1 millimeter. Here is 1.6 millimeter. Okay, before we predilate, we use a 2O burr to prepare the lesion. Okay, after prepare with rota, we recheck the OCT again. We also recheck the distance of the calcified logium tip to the lateral wall. Here, from 1 increased to 2. So after that, we predilate with 4O NC balloon and put a stand, 4O stand with 4-5 post dilation. So this is the final result of the OCT. We also find that the minimum luminal area and the minimum luminal diameter was quite acceptable here. So this is a final result of the case, and we should. But now, what should we do? We should calculate the IVA score or OCT score for the calcification we have mentioned previously. So summary for this case, for my personal opinion, I like to use the recommendation. We don't always focus on the angio. We don't always focus on the intravascular imaging. Which kind of patients we should check with intravascular imaging? So first, if angio finds the evidence of the moderate to severe calcification, we should use intravascular imaging to guide the PCI. If the angio finds only mild lesion, only for the calcified lesion, but the patient was high risk with end-stage renal disease, elderly, smoking, hypertension, or diabetes mellitus, or some very old ladies, we should pay attention to this kind of situation for the patient. Carpal lesion may be the calcified logium or loginal calcification, just because it cannot be detected by angio. So after that, we should use intravascular imaging to detect the carpal lesion. So if the carpal lesion with, look at here, severe calcification or CVI score or IVA score was high enough to perform effective weapon, just like previous PPT showed. So we can select the rota or bits or shockwave balloon or laser to treat it. If the patient was lower risk, if the angio showed a lower calcification, low mild calcification lesion, means mild lesion, calcified lesion with a low risk, okay, we can use conventional or NC balloon to predilate first, then recheck the balloon. If the full expansion of the 1-to-1 NC balloon, okay, we can stand it. If still doesn't work, okay, we can bear out to detect it with intravascular imaging. Thank you very much.